Welcome all of you to this live program, Orthopaedic Principles. Today, our guest of honor is Professor Mary Mulcahey from the United States. Professor Mulcahey is the Division Director of Sports Medicine in the Department of Orthopedic Surgery at the Loyola Medicine and Loyola University, Chicago Street School of Medicine. She received a doctorate of medicine from the University of Rochester School of Medicine. She completed orthopedic residency at the Brown University, followed by a fellowship in orthopedic trauma at the same institution. Dr. Mulcahey then went on to do a fellowship in sports medicine at the San Diego Arthroscopy and Sports Medicine Institute. Dr. Mary Mulcahey served as faculty in the Department of Orthopedic Surgery at Tulane before moving to Loyola. There, she was the director of Tulane's Women's Sports Medicine program. In that role, Dr. Mulcahey was instrumental in the design, development, and leadership of a comprehensive approach for active women. Dr. Mulcahey has been the president of the Ruth Jackson Orthopedic Society. Additionally, she's serving on the ANA Board of Directors, the AOSM Educational Committee, the AJSM Electronic Media Board, and she has been selected as the AOSM Traveling Fellow to Europe in 2022. If you've noticed, Professor Mulcahey has delivered a lecture on a channel in the past, and today is my great honor to bring back Professor Mary Mulcahey for this wonderful live program. Over to you, Professor.
Great. Thank you so much for that very kind introduction and for the opportunity to be here with you guys today. I'm excited to have the chance to talk a little bit about AC joint injuries and kind of focusing on the realm all the way from diagnosis to management and how we get our athletes back to play. And I think for any of us we see in literature, there are a lot of different ways to treat AC joint injuries when we're talking about surgical intervention. So we're going to talk about some of that stuff. So let's see here. Okay, so these are my disclosures, none of which are directly relevant to this talk. As an overview, I'm going to touch a little bit on the anatomy of the AC joint. I'll sort of refresh our memories with the classification of the AC joint injuries, go into some detail on diagnosis and management, and then highlight outcomes and return to play. I wanted to frame this in the context of a case. So this is an 18-year-old right-hand dominant male who presented to me 2 months after injuring his left shoulder. He fell on his shoulder while playing football. He had immediate pain on the superior aspect of his shoulder, and he participated in physical therapy initially for about a month. He also had a steroid injection in the AC joint at an outside clinic, and he was able to continue playing football and did relatively well until he fell on his shoulder again. So when he came into clinic, his range of motion, shoulder range of motion was actually fairly normal, a little bit of discomfort at the extreme of motion. He did have tenderness over the AC joint and obvious prominence of the distal clavicle. These were his x-rays in clinic. So we see a clear vertical displacement of the distal clavicle, a small avulsion fracture off the distal clavicle as well, but normal alignment of the glenohumeral joint. And so options at this point, right? We're considering all options. So sling immobilization, right? Potentially just to kind of rest the shoulder initially, anti-inflammatory medications, activity modification, PT. He's done physical therapy already and just had this second injury. And then when we're talking about surgical intervention, this is where there are so many different options. So doing a primary open repair, doing open reduction and internal fixation, using a loop, you can use sort of a suture type construct. We could use a graft, allograft or autograft, or performing an arthroscopic assisted procedure. So a lot of different things to take into account. And we're going to get back to this case at the end of the presentation. So a little bit about the anatomy of the AC joint. It's a diarthrodial joint that's located between the medial facet of the acromion and the lateral aspect of the clavicle. It allows gliding movement at the joint, and it assists in shoulder abduction and flexion. Importantly, it helps stabilize the scapula in relation to the clavicle by the complex ligaments and muscles that surround it. The clavicle rotates about 40 to 50 degrees with overhead motion. I don't think we often think about that, but only about 5 to 8 degrees of motion occurs at the AC joint. And as the clavicle rotates upward or superiorly, the scapula rotates inferiorly, and AC joint motion actually decreases. So this is referred to as synchronous scapuloclavicular motion. There are two main ligaments that stabilize the AC joint. There's the AC ligament and the CC ligaments, and we'll break that down a little bit. So the AC ligaments, there's the superior, inferior, and posterior components. They are thickenings of the joint capsule. And this is really important. It's the major stabilizer against horizontal translation and posterior rotational forces that are generated by scapular protraction. So that horizontal stability is really important for the AC joint. The AC ligaments are two separate bundles. There's the superior-posterior and antero-inferior. The superior-posterior actually has higher quality in terms of structural composition, but it's the antero-inferior that is also very important for horizontal instability. And then the CC ligaments, these are comprised of the conoid and trapezoid ligaments. These confer vertical stability to the AC joint. And so we think a lot about these ligaments because we see the distal clavicle really displaced. And so we know the CC ligaments are disrupted, but we also have to think, very important to keep in mind, the horizontal component as well, and the contribution to that with the AC ligaments. And the CC ligaments also work as a restraint against scapular internal rotation. This is a 2022 study looking at anatomy of the AC and CC ligaments. We noted here that the CC ligament arises from the posterior aspect of the coracoid. It inserts onto the conoid tubercle, and it's located about 42 to 47 millimeters from the lateral edge of the clavicle. And importantly, it confers 60% of the restraint to anterior and superior clavicular displacement and rotation. The trapezoid ligament inserts on the trapezoid line. It inserts at about 20 to 25 millimeters from the end, the distal end of the clavicle, and provides resistance to AC joint compression. This is a picture that we actually included in this paper too, just showing a nice picture of the clavicle and the quantitative and qualitative descriptions of the CC ligaments, but we don't have that same level of detail for the AC ligaments. And as a result of that, right, we know there are high complication and failure rates after AC joint reconstruction. So by really understanding the anatomy of the AC and CC ligaments, that can help us improve our patient outcomes. So it's really important that we continue to do research on this. The AC capsule and the CC ligaments, again, allow controlled rotation of about 40 to 50 degrees of the acromion in relation to the distal clavicle while preserving that centered motion. And it's a really important characteristic of normal scapulothoracic motion. So again, we don't often think about the role that the AC joint plays. When this gets when there's the disruption of that rotation, it actually leads to decreased function and overall poor clinical symptoms. So that's why we need to make sure we're evaluating that. The AC joint itself contributes to the strut function of the clavicle and again helps guide rotation of the scapula. It's a really vital joint in terms of the stabilization and controlled motion of the lateral clavicle in relation to the acromion. And when you have inhibited scapulothoracic function, again, less favorable outcomes tend to be experienced by the patients. In this particular study, here we go. This is a 2018 study. They noted that with posterior translational force, the specimens that had a completely cut AC capsule showed significant loss of resistance against that translational motion. So by cutting 50% of the capsule, it actually reduced resistance to torque for all segments and testing modalities when compared to the intact state. And all of the groups actually demonstrated a significant increase of motion in all directions when the capsule was cut by 50%. So it doesn't even have to be completely disrupted to cause a big problem. So they concluded that cutting the entire capsule actually reduces resistance force to less than 25% during translational testing and less than 10% during rotational testing. And that the anterior segments provide the greatest stability under rotational loading, and the amplitude of the joint's motion actually really significantly increases under rotational stress. When we talk about classifying AC joint injuries, so it's a range, right? Ranging from minor sprains and a subluxation to a complete dislocation or separation of the AC joint. Important to note that this is often associated with other injuries to the shoulder. And AC joint injuries were first classified in the 1960s by Tosi, and then further classified by Rockwood in 1984. And this is the classification system that we, of course, are all most familiar with. So type 1 with the Rockwood classification, this is a sprain of the AC joint capsule without a complete tear of the AC or CC ligaments. Patients will have tenderness over the AC joint, maybe some swelling, but we don't see any widening on the AC joint, widening at the AC joint on x-rays. Type 2 is actually a tear of the AC ligament and a sprain or partial tear of the CC ligaments. And in this case, we do see some vertical subluxation of the distal clavicle. Type 3 is a complete disruption of the AC and CC ligaments, and we see 25 to 100% displacement of the clavicle compared to the contralateral upper extremity. Also important to note, the Issaquah Shoulder Committee, now several years, further subclassified type 3 injuries into 3A or 3B, where 3A is horizontally stable and 3B is horizontally unstable, and that is an important distinction. So type 3B is characterized by overriding of the distal aspect of the clavicle on AP x-rays with a cross-arm adduction view. Patients often have substantial scapular dyskinesia that does not respond well to physical therapy. And so those patients may benefit from early operative fixation. So it is important to be evaluating for horizontal stability. Type 4 is a posterior subluxation of the clavicle into the trapezius. So this is less common. And then type 5 and type 3, we have a big discussion about this, but oh, sorry, this is another little acronym here. So type 4 is out the back door. When you're trying to remember this, right? Type 4 goes posteriorly, so kind of out the back door. That's a way that I was taught to remember that in residency. Type 5, this is again disruption of the AC and CC ligaments, but you tend to see more significant displacement of the distal clavicle. So high 5, right? So again, we're trying to think about ways to remember this. So high 5 is significant, more significant displacement, vertical displacement. And then type 6 is really rare. This is where the distal clavicle is displaced inferiorly into the subcoracoid position. And the way I was taught to remember this is just deep 6. So the clavicle is being displaced inferiorly. And then here's just kind of a summary of the classification. This is the Rockwood classification system. We just went through that, but you can see this is a JBJS article from 2014, but kind of summarizes the breakdown of the type 1 through 6 AC joint injuries. And then, as I mentioned previously, AC joint injuries are commonly associated with other shoulder pathology. So about 15 to 18% of patients have associated pathology, most commonly slap tears and rotator cuff injury. And this sort of begs the question, do we get an MRI on every patient who has an AC joint injury? I don't think you absolutely have to, but even if you do get an MRI, it's an interesting discussion to talk to sports and shoulder surgeons to say, if you find pathology on that MRI, are you treating it, or are you only treating the AC joint injury initially? And so we won't go into detail now, but just know that there are commonly there's commonly other intra-articular pathology. In terms of mechanism of injury, so injuries to the AC joint account for about 12% of all shoulder injuries. They are about 5 to 10 times more common in males and tend to occur in the first 3 decades of life. It's usually the result of a direct blow to the shoulder. So the arm is in a position, it's an adducted position, and the patients fall directly onto the shoulder. This can happen quite frequently in bicycling, skiing, hockey, rugby, football, those types of sports. There can be, if there are more severe forces, downward forces, that can actually result in tearing of the deltoid and trapezius muscles from the clavicle. That's less common. And then some uncommon mechanisms of injury include like a traumatic force or substantial pull through the upper extremity, or a lateral directed force as the scapula externally rotates. But most commonly, it's a fall directly onto the shoulder. In terms of diagnosis, certainly we rely a lot on the clinical presentation. So we want to suspect an AC joint injury in any patient who has some type of shoulder trauma in the vicinity of the AC joint. They may have injured the upper extremity in that adducted position. And then, of course, with localized pain, swelling, and tenderness over the AC joint, we want to make sure we're evaluating that. Also on exam, patients will often have pain that's worse with abduction and cross-body adduction. They may have tenting of the skin by the distal aspect of the clavicle, which you can see in this picture. They may have SC joint pain if they have a type 4 injury. And then patients with type 5 or 6 injuries may have pain in the neck or trapezius in association. On exam, this is just showing cross-arm adduction test. So the arm is elevated to 90 degrees of forward flexion and then adducted across the chest. And then there's Paxino's test, which you evaluate tenderness by applying thumb pressure directly at the AC joint, but on the posterior aspect. And yeah, okay, perfect. So yeah, so we can show that. That's just a picture here demonstrating Paxino's test. And then O'Brien's test, this can actually help you determine whether the pain is caused by an injury to the AC joint or related to the labrum or the biceps complex. this is where the arm is forward flexed 90 degrees, adducted slightly across the body, and then downward pressure is applied by the examiner. And pain that's referred to the AC joint is more indicative of an AC joint injury. Pain that's referred to the glenohumeral joint makes you think about possible labral or biceps pathology. Of course, I've mentioned this several times, but it's a really important point to take away is that we want to make sure we evaluate for horizontal instability. And this is a video that's courtesy of one of my practice partners at Tulane, Dr. Mike O'Brien. And so just to try to show that again, right, the horizontal instability there of the AC joint. And patients will often complain. They'll complain of like a clicking sensation, or did they just feel this movement that is more characteristic of horizontal instability than just that vertical displacement. X-rays, of course, are critical. We'll, often at least get standard shoulder X-rays, so a true AP, axillary lateral, and a scapular Y. We know the Zenka view is designed specifically to really evaluate the AC joint. And just an important point for anyone out there taking tests, in training exam, et cetera, a Zenka view uses half the X-ray exposure that's used in the standard X-ray of the shoulder. And then some sort of historical information about like what do we see on imaging. So the average distance between the superior aspect of the coracoid and the inferior aspect of the clavicle is about 1 to 1.3 centimeters. A 40 to 50% difference in the CC interspace between normal and affected shoulders indicates a complete disruption of the CC ligaments. And then Rockwood's textbooks in 1990 documented complete disruption of the CC ligaments with side-to-side CC differences of 25%. So yes, you can make that measurement. A lot of times, you see the significant displacement, and obviously it's difficult sometimes to say, is that 100% displacement? Is that 200% displacement? But the vertical displacement is, of course, obvious on imaging. So a little bit more about horizontal instability, some key points, right? This is often missed, and it can lead to patients who have chronic pain and functional limitations. They can present clinically with significant shoulder pain and associated disability, and it's difficult to diagnose with standard X-rays. So we looked at this a few years ago now, and so some recommendations in terms of imaging include getting the Zenka view. You can also look at this on the axillary lateral view. Other types of imaging, a little bit more specialized, are the Alexander view and then the supine dynamic lateral view. So the Alexander view I've demonstrated here. So this is where the arm is in an adducted horizontal stress position and the scapula is anaverted, and you can see the resultant image on the right-hand side. And then the supine dynamic lateral view, the arm is abducted to 90 degrees in the scapular plane, and then transitioned from a few different positions. Now, the practicality of this, right, is low. Like, this is difficult to do routinely, but just to give some ideas that there are certainly some imaging, some types of imaging that can be done to better evaluate for horizontal instability, but also we need to evaluate for this just on physical exam. And in general, there's no consensus really regarding best practices for diagnosis, evaluation, and treatment of horizontal instability. Really what we need to try to do is just raise awareness about the importance of evaluating for this, because it does have significant implications for patients. MRI is, again, not necessarily the first choice for imaging. We're always starting with X-rays, and MRI will show us, obviously we're going to know that there's disruption of the CC and AC ligaments. It will also show us the intra-articular pathology, but then it really begs the question, are we doing anything about that either at the same time or at a separate time? And yeah, as I said, it'll be helpful to identify associated pathology. In terms of management, so going through the Rockwood classification here, types 1 and 2 are treated non-operatively, right? Patients will be placed into a sling, take some anti-inflammatory medications, modify activities, and usually participate in physical therapy. And that helps tremendously. And patients usually do quite well. In general, they'll refrain from playing contact sports and heavy lifting until they're pain-free and have symmetric range of motion, but it doesn't usually take them that long to recover from this low-grade injury. This is a study, a relatively recent study out of AJSM. So they looked at patients with treatment for type 1 and 2 AC joint injuries, and they looked at some outcome measures, and they also looked at radiologic outcomes, which I just wanted to draw attention to here. So patients had similar rates of degeneration, but there was more frequent osteolysis of the distal clavicle and ossification of the ligaments and deformity of the distal clavicle in these patients. So they concluded that there are frequently changes on X-rays, but the long-term functional outcomes after type 1 and 2 AC joint injuries is really good. So those radiographic changes don't obviously don't impact what we're going to do clinically. So again, these are clinically non-relevant functional differences between the injured and contralateral side. And then type 3, this is where the controversy comes in. So to really maximize function, some surgeons advocate for early surgical intervention for type 3 AC joint injuries in young and active patients. The optimal treatment, right, whether that's operative or non-operative, for an athlete who plays an overhead sport and has a lot of functional demands may be different from those that are older or less active. So I think still in general, we aren't routinely pulling the trigger or advocating for surgery straight away in these injuries, but certainly it's an important consideration for high-level athletes. Here looking at operative versus, it's a difficult title, but there we go. We go back to this previous slide. So here looking at meta-analysis of type 3 AC injuries, they found that operative management actually resulted in a better cosmetic outcome, right? So maybe you have less of a bump and a greater duration of sick leave, of course, because they had surgery, but there was no difference in strength, pain, the ability to throw, or the incidence of developing osteoarthritis at the AC joint compared to non-operative management. And the rate of recurrence in this, this is a separate study too. So rate of recurrence of the surgical group was about 14%. There was no statistically significant difference between operative and non-operative management in terms of postoperative arthritis or persistence of pain. So one thing I'll tell patients, and certainly we talk about collectively as sports and shoulder surgeons, is and a reason why we don't go straight to surgery is that the patients are very likely still going to have at least a little bit of a prominence, a little bit of a bump, but then with surgery, they're also going to have a scar. So they'll have a scar and a bump instead of just a bump. So that's just something that's important for them to understand. Of course, those with significant functional limitations, scapular dyskinesia, the horizontal instability, right? Those are patients that do benefit a lot from surgery. So based on these studies, there's insufficient evidence to establish the effect of surgical versus non-operative treatment in functional outcomes of patients with type 3 AC separation. So of course, we need to do more research and really try to do randomized controlled trials. So based on the current literature, there doesn't seem to be much of a difference between operative and non-operative management of type 3 injuries. So the overall recommendation is to start with non-operative management, have patients do physical therapy, a little bit of activity modification, and then consider operative intervention in patients who have significant AC joint deformity, who have tenting of the skin. Certainly, we don't want the skin to be threatened, have persistent pain despite a course of non-operative management, and then patients who have higher functional demand, right? Whether that's with work or sports. So these are all things to take into account when we're making a decision. A few comments about scapular dyskinesia. So this is a clinically important consequence of non-operative management of AC joint injuries. It's an alteration of the normal position or motion of the scapula during that coupled scapulohumeral movement. And the dyskinetic pattern actually is broken down into 3 different categories characterized by the prominence of the inferior medial border of the scapula, the entire medial border, and then the superior medial border. And then we've all heard about 6 scapula syndrome. So this is scapular malposition, inferior medial border prominence, coracoid pain and malposition, and then dyskinesis of scapular movement. This study looked at scapular dyskinesia and 6 scapula syndrome in patients with AC joint injuries that were chronic in nature. They found that about 70% of patients had scapular dyskinesia with the arm at rest. 2/3 had prominence of the inferior medial border of the scapula. About 58% had 6 scapula syndrome. And their constant score was definitely impacted. So they concluded that chronic type 3 AC separation actually causes scapular dyskinesia in about 70% of patients. So that is a lot, of course. And it might be due to the loss of the AC joint as the stable fulcrum of the shoulder girdle, which we talked a lot about earlier on. And then when we look at types 4, 5, and 6, so there are a lot of surgical techniques described for the treatment of type 3 or type 5 AC joint injuries. I think there's like 160 techniques, which just tells you that there's no one technique that is way better than all the others. So possible options include open reduction. You can do a direct repair of the AC joint capsule. You could do rigid internal fixation, like with a hook plate. Ligament reconstruction or a combination thereof, right? Complications and pain that patients experience postoperatively can be attributed to the implants or progression of the AC joint. And then in terms of additional details related to surgery, so there's definitely been in the past 5, maybe 10 years, discussion about the use of arthroscopically assisted or all arthroscopic reconstruction of the CC ligaments. Some advantages of arthroscopy, of course, include the ability to evaluate and treat concomitant intra-articular shoulder pathology. It minimizes the soft tissue dissection. We can reduce skin and wound complications, and then maybe facilitate earlier rehab. So there's definitely some surgeons incorporating that. I think still many will do an open AC joint reconstruction. I included this just a little bit of information if anybody's interested in learning more about arthroscopic techniques. So there's several published in terms of different options, and so you can get more details with referring to that. In terms of some elements for successful outcomes of AC joint surgery, right? We, of course, want to have an anatomic and accurate reduction of the AC joint to correct that superior displacement and address the horizontal or A to P translation if the patient has that. We can do a direct repair or reconstruction of the CC ligaments. Usually we're reconstructing the CC ligaments. We can supplement or protect the CC ligaments with several different things. We can put a graft over the AC joint. We can use anchors. We could use a synthetic type graft with tape. We could use a hook plate. So there's several different things you can use. You also want to make sure to repair the deltoid and trapezial fascia. And then you can consider resecting the distal clavicle if the clavicle won't reduce appropriately. I don't think that's a routine practice for most surgeons, but it's definitely if you need to, right, you can resect a little bit of the distal clavicle. And so this was kind of a current concepts paper. They found 821 different references, 20 studies were included. They had about 14 comparing operative versus non-operative management, 4 comparing early versus delayed, and 2 compared anatomic and non-anatomic techniques. This is a key point and why it's in bold. 120 studies describing 151 techniques to reconstruct the AC joint. So there are a lot of different ways to do this. When looking at operative versus non-operative intervention, there were favorable outcomes in about 80% of operative patients and 85% of non-operative patients. Return to work and return to sports was overall quicker for patients treated non-operatively. Those with early versus delayed surgery, there was a favorable outcome in about 90% of patients treated early and 70% of patients treated in a delayed manner. I think in general, again, we're usually not operating straight away in these patients, so we're letting them do some physical therapy because most of the time they're going to improve. And if they don't, then we're doing a reconstruction, usually using an allograft and with or without sort of suture augmentation. And then anatomic versus non-anatomic, there were more favorable outcomes with the anatomic technique. So they concluded from this that there's really a lack of evidence to support treatment options, like one specific treatment option for AC joint injuries. And of course, more research will help us kind of better define what the appropriate option is. Here, just kind of jumping to the last bullet point, right? Combined reconstruction of the AC capsule and CC ligaments is really important. That achieved actually the highest percentage of regained resistance torque, but it remains significantly weaker still than the native specimen. So native translational stability can be restored by the addition of AC capsule augmentation, but the patients still have partial rotational instability. So really important to keep in mind, again, the contribution of the AC ligaments and the capsule. Now, when looking at autograft versus allograft for AC joint reconstruction, there's not really great evidence out there comparing allograft versus autograft. There don't seem to be any significant differences in clinical outcomes between graft types, and providing additional horizontal stabilization, it leads to a lower rate of loss of reduction. You can also use a suture tape to kind of augment the allograft, and that also reduces the loss of reduction and revision rates. Transitioning a little bit to outcomes. So this is a 2018 study out of arthroscopy where they looked at several different treatment modalities, and they found that they all really improved patient outcomes, but using a hook plate and K-wires had the highest rate of complications, understandably. They looked at unplanned reoperation rates, and there were 5% of those with modified Weaver done had an unplanned reoperation, 2% to 3% with hook plate and K-wires. And this is just kind of some kind of cartoon diagrams demonstrating different techniques. So you see suspensory device, here's the hook plate. Some you can also do a CC ligament reconstruction using allograft or autograft if you wanted to, and then augment that with a hook plate. So there are a lot of different options. They concluded from this that there are comparable subjective outcomes after operative treatment of AC joint injuries for all modalities, relatively overall a low unplanned reoperation rate. Of course, treatment with K-wires, that does scare me. And hook plates were associated with the highest complication rate. And this is a study that we did, and so it's currently under review, looking at complications following placement of hook plates. The most frequent complications were osteolysis, loss of fixation, and infection. And hook plate fixation that's augmented with a suture tape or suspensory fixation may actually lower the rate of osteolysis and improve short-term functional outcomes postoperatively. I wanted to just, this is sort of a mini case presentation within the talk, but speaking about complications from hook plate. So this is one of the patients, one of my patients who had this AC joint injury. It was several months. He may have even been a year out from this injury. Overall, his glenohumeral joint looks fine, but obviously you see the vertical displacement of the distal clavicle. So we moved forward with AC joint reconstruction. He had done everything. He had done all the conservative treatment and really had no improvement in his symptoms. So I did the CC ligament reconstruction using allograft. We got great reduction of the distal clavicle and then supplemented that or augmented it with a hook plate. Had great placement. I was very happy with this. These are his initial post-op x-rays. On the far left, you see the intraoperative picture, the placement of the hook plate. And then we can see these two images showing that the hook is under the acromion. And then he came back to clinic. Now this is about 4 weeks post-op. So I saw him initially at like 1 week post-op, and then he came back at 4 weeks. And you can see that the hook is kind of eroding through the acromion. This patient was in his early 50s. And we know in general, the acromion, even in young patients, is not a very big bone, not a very robust bone. But as we get older, of course, that bone is weaker. And so the hook just cut right through the acromion. So what do we do here, right? This is like, you're not too happy when you see this in clinic. So what are we thinking about doing? Well, do we want to run and hide? That's what I wanted to do when I first saw that x-ray. Do we say, well, I mean, it's okay. Let's just leave it as is. Maybe have him come back in a month and we'll just kind of see how he's doing. Or do we just bite the bullet and say we need to take this hook plate out? So, we don't want to be the ostrich. We don't want to stick our head in the sand and pretend like there's nothing wrong in this situation. And so the bottom line is like, we just have to address it. So for him, and I didn't include these pictures, but we brought him back to the OR. That was like within a week, brought him back to the OR, took out the hook plate. And we didn't have to address his acromion, but I obviously didn't want to leave that in and have that displace even more. So transitioning to return to play. When we're looking at return to play after AC joint injury, so this is a systematic review from a few years ago. Here, they found that mean follow-up was relatively good, looking at about 3 years post-operatively. The sports that were most commonly played were rugby, cycling, and soccer, and the overall rate of return to play was 94 to 100%. So in general, patients do pretty well. And the rate of return to pre-injury level of sport ranged from about 60 to 100%. Getting back to sports after type 3 versus type 5 injuries was quite similar. And then a few comments about rehab protocols. So patients, there was quite a variation. So patients wore a sling anywhere from 2 days to 6 weeks. Passive range of motion started anywhere from post-op day 1 to 3 weeks post-op. Active range of motion from post-op day 1 to 7 weeks post-op. Strengthening exercises, right? You see the theme here. There's a lot of variation. And then return to sport criteria, having strict time-based cutoffs ranged anywhere from 6 weeks to 6 months in terms of getting back to return to play. And there was, of course, an earlier return for non-contact sports and delayed return for contact sports. So those things make sense. Overall, they concluded that there's a very high rate, almost 100% rate of return to sport after operative management of AC joint injuries. Most patients are actually able to return to the same level of play as well. And the rate of return to sport is comparable across different types of injuries and different surgical procedures. But key takeaway here too, right? There's clearly a lack of universal guidelines for post-op rehab and return to sport following AC joint injuries. So getting back to our case, just so everybody remembers, this is an 18-year-old right-hand dominant male football player who presented with a type 3 AC separation. He had not had any improvement with PT and anti-inflammatory medication, and so elected to move forward with AC joint reconstruction. So I've included some intraoperative pictures, and we have some videos on subsequent slides too. So on the far left, we're using this hooked type device to pass around the coracoid, and many companies have this. You can feed out a little wire and then use the wire to pass a suture around the coracoid, which will then ultimately be used to pass the graft. In that central picture, I'm just using a ruler to mark out the location for 2 drill holes. So I'm going to make 2 tiny drill holes, which you can see on the far right, with a 2 mm drill. And so I'm drilling those at the location of what would replicate the conoid and trapezoid ligaments. So roughly 20 and 40 centimeters, or 20 and 40 millimeters rather, sorry, from the distal clavicle. And then here is a video just showing passing the graft around the coracoid. So I'm passing the graft, and I'm also passing a suture tape construct because I'm going to use that to augment the graft fixation. You can just see that again here too, pulling that around the coracoid. And then we have a couple other videos here. And sorry, I'll try to put that down. Okay. So in this video, I'm going to pass the graft actually around the posterior aspect of the clavicle. So we passed 1 limb around the posterior aspect of the clavicle. We already have the graft completely around the coracoid. And then, oh, sorry, that particular clip, I think it's on the next clip. This one on the left-hand side, and we can see this again, I'll show you, is I'm pulling the tape. So there are 2 limbs of the tape. Again, I had passed the graft and the tape around the coracoid. I had drilled those 2 small holes in the clavicle. And then we pull the 2 limbs of the suture tape up through the clavicle, up through those tiny holes. And those 2 limbs of the tape are going to be used to tie over the graft. And then here I'm pulling the graft around the posterior aspect of the clavicle. So here is 1 limb of the graft. There you go. You can see that. Okay. And then we'll jump to this slide. So a few still pictures here too. On the far picture is after we've passed the graft around the coracoid. We passed that at the same time as we passed the suture tape. And then in the far right is just a picture showing that kind of hooked device again. So I had passed that around the posterior aspect of the clavicle, fed through the wire, used the wire to then pull a passing suture around the clavicle so that I could subsequently pass 1 limb of my graft. And then, okay, there we go. So now I'm tying the graft over the clavicle, right? And we're holding the AC joint reduced, so you can manually sort of push down on the distal clavicle and push up a little bit on the elbow, and then tie the suture tape. So we tie the graft, and then after the graft is tied, I actually will use like an O-vicryl, or you can use number 1 vicryl to tie that, to just kind of like supplement that, and then tie the suture tape on top. And so this is the graft tied. I'm just using the vicryl there to kind of augment that. And then on the far right is tying the suture tape on top of the graft. And when I tie this too, when I tie the graft itself and the suture tape, I want to make sure that we're making sure that 1 limb is longer so that I can then bring the long end of the graft and a 1 limb of the tape over the AC joint. And we use that to actually help stabilize the horizontal instability, right? So we're stabilizing the AC joint in that direction as well, the A to P direction. So on the far left, you just see the graft itself, the long limb of the graft with the suture tape on top. And then on the far right, we're starting to suture that into the surrounding tissue as the graft is placed over the AC joint. And you can see that here in the picture on the left. And then on the right is the final construct. And then, of course, we close the delta trapezial fascia and the subcutaneous tissue. These are his post-op x-rays. On the left, on both of them, if you look closely, you see 2 tiny holes. Those are the 2 mm holes that we drill to actually pull the tape up through the clavicle. And that tape, again, is used to kind of augment fixation over the graft. So in summary, the AC joint is really, really important. It assists in movement of the arm. AC joint injuries are often caused by a direct blow to the shoulder in contact sports. The Rockwood classification system is helpful to us, right? It is used to help determine the extent of injuries and to some extent surgical treatment. And then non-operative or operative intervention really depends on the severity of the injury and also the patient's symptoms. And there are so many techniques that we can use to treat AC joint injuries operatively, 150 or 160 to be exact. So thank you so much for your attention, and thanks again for the opportunity to share this with you.
Thank you so much, Dr. Mulcahey. Dr. Mulcahey, you can stop sharing. Thank you once again, Dr. Mulcahey, for this wonderful presentation.
My pleasure.
Dr. Mulcahey, a few questions. Now, in clinical practice, how often do you get stress X-rays or the Zanka or the Alexander view? Alexander view is not very popular, right? So how often do you do it in clinical practice?
Really never. I just put it out there to say, like, those are the more, technically based on research standpoint, and maybe if you were doing a study, you would include those views, but clinically and for like the flow of clinic, no, we don't. We get standard shoulder X-rays. Good
And
question. What do you do? I mean, yeah, I would be curious to know, like, but
exactly,
I think, like, in
because
general,
very rarely, I mean, we don't do the stress X-rays, right? The question comes between the type 2 and type 3. So that is where people get confused. I mean, it's not really displaced, but is it completely displaced kind of? So in the past, I
yeah,
remember we used to be taught, I mean, the original in the previous editions of Rockwood, you tie something on the wrist, and someone said, okay, no, you don't tie it, you
no.
want them to hold it, right?
Yeah, no, like weighted views, like stress views. Yeah. And certainly, like, when I was in residency, we were taught that too. And I wasn't a resident that long ago, but like that's, that definitely we were taught that that's the best way to evaluate. But routinely and in clinical practice, we don't do that. We get just standard X-ray views. So true AP, axillary lateral, scapular Y. You are looking grossly at it, right? You see the amount of displacement, and then it comes down a lot to functional limitations. And I think still in general, the standard is to do a trial of non-operative management, because most of the time patients are going to get better. Men certainly tolerate this fairly well because they don't have anything, like no bra straps, no purse, like nothing that they're routinely having to like put over their shoulder. So it's a little bit more irritating in women, but overall the injury is more common in men.
And interestingly, you showed one of the papers written by Knut Beetzel, right? Yeah, so I've hosted him for a similar program around 2 years back. The systematic
Yeah,
review.
yeah, exactly.
Dr. Beetzel
He's
and
fantastic.
Dr. Mazoka, Augustus
Yeah.
Mazoka.
Oh, yeah. World experts in AC joint injuries. Absolutely. And I mean, a lot of the literature that we see, right, come Gus Mazaka and the group out of UConn. I mean, Dr. Mazaka is now, of course, at MGH, but Dr. Arciero and Dr. Mazaka have done a ton of work, really a ton of the biomechanical work. And so we owe a lot to them for our understanding of the AC joint.
And Dr. Mulcahey, in your presentation, the surgical technique, the graft which you used, what are the source? Is it an allograft that you used?
It was allograft. Yep. And so I think it's an important point to bring up. Like, I touched on it briefly in the talk that you can use either allograft or autograft and get very good outcomes. I think in part it probably comes down to maybe where you are in the world. Like, I mean, in the United States, I'm lucky we have pretty easy access to allograft. That's not a limitation. So when I do AC joint reconstruction, I'll use allograft. But it's expensive. It is expensive. And then there are some places in the world where you just can't even access it. So bottom line is you can absolutely use autograft to reconstruct the CC ligaments.
Thank you, Dr. Mulcahey. And Dr. Mulcahey, you mentioned about the hook plate. So have you abandoned the use? I mean, you showed that X-ray. Have you abandoned? And do you think there is a difference between the usage of these techniques among trauma surgeons? And suppose you take the OTA group and you take the AOSM group. Now, do you think the treatment approach from the trauma surgeons would be different from the shoulder? Because they would use more of open techniques, hook plate, and the shoulder surgeons are going to use arthroscopic techniques, the dog button, etc.
Yeah, it's a very, very good question. Excellent point. I like I don't like the hook plate. It scares me. I'm not gonna lie. But so but I was at Tulane for 6 years, as you mentioned early on, and two of my partners there who are phenomenal surgeons, absolutely phenomenal shoulder surgeons, use the hook plate a lot. and have used it not on 100% of their AC joint injuries, but they use it quite commonly. And they like it. I just don't like it personally. So I had, a small handful of cases and just didn't love it and had like that instance, and it just is not a good feeling. So I personally have abandoned that. But when we talk I mean, I think you can get excellent outcomes. Clearly, if you use it, it has to come out, right? It comes out eventually. And I don't know. I think my inclination would be like, yeah, the trauma surgeons, if they want to tackle, AC joint injuries, that they probably would feel quite comfortable doing a hook plate often. But and that, the shoulder or sports surgeons are more often trying to do the sportier stuff and, doing augmenting with these special implants or suture tape or, internal brace, whatever you want to say. We can also augment, like put a suture tape across the anterior aspect of the AC joint. So as sports and shoulder surgeons, I think we're going to be leaning more towards that. But hook plate is still very much out there. It definitely in no way abandoned, just because I've abandoned it because I don't like it. It's still actually used like fairly commonly for AC joint reconstruction, as either in isolation or like oftentimes kind of augmentation. So reconstructing the CC ligaments and then, using the hook plate. And I think an interesting question and variation that I've seen even with some of my colleagues is, do you put the graft under the hook plate or over the hook plate? Like, I mean, to me, it makes sense to put it under, because when you take the hook plate off, you don't want to disrupt what you've put on. But some of my colleagues who have excellent results put the graft on top of the hook plate. And so anyway, that's just a separate kind
And
of
Dr.
discussion.
Mulcahey, in future, would you go to a full arthroscopic? Now you have abandoned the hook plate, you started with the grafts, and do you think, are you going towards a fully arthroscopic procedure?
I don't know. I don't think I will personally. I mean, I've played around with that a little bit in the lab. I have not attempted to do that, certainly all arthroscopic or arthroscopic assisted. I still think in general, as you see, there's really no standard for surgical technique for AC joint reconstruction, but I still think the vast majority of sports and shoulder surgeons are doing AC joint reconstruction as an open procedure.
Thank you, Dr. Mulcahey. I think that's all the questions that we have for the session. Thank you for yet another brilliant presentation, and congratulations for being promoted as professor, and really look forward for more from your side.
Great. Thank you so much for this opportunity. I really appreciate the discussion. It was a lot of fun.
Thank you so much. Bye-bye.
Great. Have a great day. Take care.
Take care. Bye.
Bye.